Thank you, Sidra and the Glodem team for giving us the opportunity to present us in today's forum. So we'll straight away move on to the case presentations. There will be 3 cases discussed by 3 of us trainees and followed by the main presentation by our supervising consultant, Dr. Akarawita. So our first case, case number 1 is regarding a 60-year-old female who presented with a non-healing ulcer on her left forearm for 1 year duration. Actually, this is a patient who was under the care of Dr. Chandani Vikramaratne, consultant dermatologist. So I must thank her for allowing us to present this case today. So according to the patient, this lesion appeared spontaneously and it gradually enlarged and it was a painless ulcer. And she denies any constitutional symptoms. There is no past history or contact history of tuberculosis. And she had undergone several skin biopsies earlier and had been treated as for cutaneous leishmaniasis and atypical mycobacterial infections, but with poor response. She did not have any clinical features or investigations findings compatible with sarcoidosis, connective tissue diseases, vasculitis, or malignancy. On this presentation, she again undergone a skin biopsy which revealed a dense lymphohistiocytic infiltrations with many granulomata composed of multinucleated giant cells of both Langhans and foreign body types. And few granulomata showed foci of necrosis, but no foreign bodies noted. Special stains and cultures were negative for organisms including Mycobacteria, leishmaniasis, and fungi. So, and also the tissue biopsy for TB PCR, sputum analysis for acid-fast bacilli, TB quantiferon gold tests were all negative. So basically the patient, the diagnosis was conclusive at the beginning. But during the evaluation, during present admission, she developed a persistent cough. And she has undergone a chest X-ray which revealed a patch of bronchiectasis of the left lingual lobe. And the HRCT also showed some fibrotic lesions with calcifications involving the left lung along with mediastinal lymphadenopathy. Then with the aid of the chest team, the patient she had undergone a bronchoscopy which showed whitish extensive plaques along the trachea with thick secretions coming from bilateral bronchial trees. And according to the chest physicians, this was very highly suggestive of tuberculosis. Although her initial evaluation for tuberculosis was negative, with the opinion of the chest team, a diagnosis of pulmonary tuberculosis with associated lupus vulgaris was made. And she was started on antituberculous treatment, including rifampicin, isoniazid, ethambutol, and pyrazinamide. This was continued for the plan was to continue as for conventional pulmonary TB management. And she responded well within 2 months of treatment. Therefore, since the patient has responded to a trial of tuberculosis and also going along with the opinion of the chest team, the diagnosis was confirmed and the anti-TB treatment continued further. And this is her response. The ulcer healed very well and the patient was happy as well. So the diagnosis was confirmed basically on the bronchoscopic findings as well as trial of anti-TB treatment, response to trial. So that is the first case. The second case is regarding a female with leg ulcers. So that will be presented by Dr. Subani. Over to you, Subani.
Thank you, Sadareka, and thank you, the GLODEM committee, for giving us the opportunity. So this is regarding another patient who presented to us with recurrent leg ulcers. So if I may go into the history, she was a 52-year-old female patient who presented with painful nodules over bilateral calf region as well as the sides of the calves, which were followed by ulceration. And these were recurrent episodes, and these ulcers healed with scarring. This patient too denied any systemic symptoms, but however, there was a history of pulmonary tuberculosis in her brother, and they had a close contact history as well. On examination, this is a photo revealing some of the leftover pigmentation and the scars. In addition, she had two small ulcers on her left calf with erythema and induration in the background. And also she had multiple scars at the previous ulcer sites, and there was also post-inflammatory hyperpigmentation. However, her BCG scar was present, as BCG vaccination is routinely done according to the EPI schedule in Sri Lanka. The investigations revealed she had an ESR of 60, and she underwent MAN2 testing, which is the tuberculin skin test. It was read as 15 millimeters. Generally, the cutoff would be taken as 10 millimeters for the BCG vaccinated individuals. So 15 millimeters was considered positive in this case. Also, she underwent skin biopsy from a fresh lesion, which showed lobular paniculitis with vasculitis. So we performed a chest X-ray on her, but there was no evidence to suggest pulmonary tuberculosis, including any fibrotic changes or any consolidation involving the apical regions of the lungs. With the MAN2 positivity and the clinically suggestive history compatible with erythema induratum, we referred the patient to the chest physicians. In Sri Lanka, the chest physicians have the authority to prescribe the anti-TB medication. So in this case, the chest team prescribed anti-TB treatment. A primary focus, of course, could not be found in this patient. However, she was prescribed anti-TB treatment for 6 months duration, which is the routine treatment period for pulmonary TB. And following the 6 months, she was free of any new lesions and anti-TB treatment, and she's not developing any new skin lesions. So with that, I would like to invite Dr. Kalani to present her third case.
Thank you, Subhani. And I also want to thank GLODEM committee to giving us this opportunity. My case is about 50-year-old male who is present and previously healthy male. And he presented with an asymptomatic skin lesions over the right elbow region since last 3 months duration. This is actually a very fresh case. And he gives a history of cleaning a fish tank about 2 to 3 weeks prior to the occurrence of these skin lesions, and he is not from a leishmaniasis endemic area and no past history or contact history of tuberculosis. And on examination, I think you can see in this picture also, there are multiple skin colored, discrete and firm papular skin lesions over the right elbow region, and those were not ulcerated. And we did the diascopy, which was negative for apple jelly nodules. And also we found that there's a single firm subcutaneous nodule palpated just above the these just about these skin lesions, and axial lymph nodes were not palpable, and BCG scar was present in this patient. Then we did the basic investigations, including the full blood count and CRP. Those were negative, and those are normal, and ESR, which was 20, and chest X-ray and MAN2 we did. Both the, we couldn't find any abnormalities in those two investigations. And the histology revealed multiple granulomata with Langerhans and foreign body type giant cells, which is compatible with our working diagnosis of fish tank granuloma, and his special stains are still awaiting. And with this background, our working diagnosis is fish tank granuloma, which is a atypical mycobacterial infection caused by Mycobacterium marinum. And he was just commenced on oral ciprofloxacin 500 milligram BD and oral clarithromycin 500 milligram BD only now just 1 week back. We are awaiting results of the treatment actually. Usually we are continuing the ciprofloxacin and clarithromycin combination regime for 6 weeks or until all the lesions fully heal. Thank you.
So that will be the end of the 3 presentations. So this will be followed by the main presentation by consult dermatologist Dr. Akarawita. So I'm going to stop sharing my screen.
Thank you. So I think the audience is from world over. So let me greet you as good morning, good afternoon, and good evening. And I think first I must thank Sidra for the whole initiation of formation of this GTC committee and taking the first to continue this and inviting us to for today's discussion, and also Akash and Emily, I think very supportive work. So today we'll be talking about cutaneous tuberculosis and non-tuberculous Mycobacterium infections. And under that, I will be talking about cutaneous TB and tuberculids, which are sort of an immunological reaction, and also about cutaneous manifestations of non-tuberculous mycobacterial infections. So we know the Mycobacteria, that's a genus which has aerobic, includes aerobic bacilli, which are rod-shaped and non-spore-forming. The important thing here is they have a lipid-rich, long-chain mycolic acid cell wall. So this is the main feature where we do the staining as well, acid-fast staining, where once it is stained, the stain remains. So that is one method we find them in the tissues. So they live in variety of environmental habitats, including natural waters, drinking water, distribution systems even. So that is how some of them get into our skin. The other important feature in them is ability to replicate at a low rate. So especially Mycobacterium leprae, we know very slow dividing bacillus, but even the tuberculosis and NT bacilli divide very slowly. So the clinical implication is they are decreased susceptible to some antimicrobial agents due to this feature. Then we can see the main So there are about 140 species coming under the genus Mycobacteria. So the clinically important ones are about 25, and they can be divided into Mycobacterium tuberculosis complex and non-tuberculous Mycobacteria and Mycobacterium leprae and lepromatosis. So actually the leprosy, Mycobacterium leprae, is a separate area where we are not going to talk about today. So we'll be concentrating on these two areas mainly. And so under the Mycobacterium tuberculosis complex, we get Mycobacterium tuberculosis, and the main other important thing is Mycobacterium bovis, which causes about only 1 or 2% infections, and also BCG, Bacillus, Calmette, and Guerin, that also comes under this complex. Then we have this non-tuberculous Mycobacteria, NTM group. So they are divided to rapidly growing Mycobacteria and slow growing Mycobacteria. So we'll be talking about several infections caused by these organisms as well. When we switch out to Mycobacterium tuberculosis, there are a range of clinical manifestations depending on the route of infection as well as the immune state of the person being infected. So, so these are the clinical entities you can see on the right side and on the left side. That indicates the immune level. According to the immunity level, some patients have multibacillary forms, and when the immunity is high, they develop paucibacillary forms. So we get few bacilli in the lesions. Here we get a lot of bacilli in the lesions. So in a novel host, direct inoculation will cause tuberculous chancre or primary inoculation. Then when there is low immunity, the contiguous spread can cause Scrofuloderma, and when it is auto-inoculation from the internal focus, Orificial infection causes Orificial tuberculosis. Then hematogenous spread causes acute miliary cutaneous TB, where it is widespread lesions, and few lesions with hematogenous spread causes tuberculous gamma. So all these categories, the immunity is low in these patients. In high immunity, direct inoculation will limit the infection to the site and causing Warty tuberculosis or varicose acutis. Then high immunity with direct inoculation, Lupus vulgaris, sometimes the lesions may progress into Lupus vulgaris other than Warty tuberculosis, but commonly Lupus vulgaris is due to hematogenous spread from the patient's internal focus itself. And in this, the immunity level, when it is very high, the low at the extreme end lies the tuberculids, where we cannot find the organism, but particles of the organism may be demonstrated in the tuberculids. So these are the three categories which we will be talking about in a while. So the main pathological feature will be the tuberculid granuloma. This is a picture of varicose TB in contrast to the other forms, which has a bit of hyperkeratotic area with papillomatosis and showing the granulomas in the deeper tissues. Here we can see the granuloma formation with Langerhans cell type giant cells and covered with lymphocytes. So there will be sheets of lymphocytes covering the granulomas, well-formed granulomas with Langerhans cell, Langerhans type, the giant cells. So the diagnosis. So I am talking about the diagnosis and the test in common to all the Mycobacterium tuberculosis infections on the skin. So this is suggested. The diagnosis initially we suspect according to the clinical features, and histological findings will also give us support for the diagnosis. But anyway, absolute criteria for the diagnosis is demonstration of Mycobacterium tuberculosis infection in the tissues by the positive culture or smear or the demonstration of Mycobacterial issues. But anyway, there are occasions, as we discussed with the first case in our case presentation as well. There are occasions where we can't do that because the culture also not always becoming positive. So there are significant proportion, about 40% may not grow the bacilli in the culture. And the other thing is the culture takes about 6 weeks to give the results. So meantime, we may have to consider other features for diagnosis and initiation of treatment. In that case, PCR will be a valuable test. So these are the other criteria we can consider active proven tuberculosis elsewhere in the body, like in the first case, the chest. Presence of acid-fast bacilli in the lesion itself. So if we can demonstrate them in the tissue sample with seal-Nielsen test stain, we can prove the diagnosis. A positive reaction to tuberculin. So that is interpreted in different contexts. And also positive interferon gamma release assay. The other one is the effect of specific therapy. In strong clinical suspicion, you may go ahead with treatment and give a trial of treatment and see whether the lesions improve, and so continue accordingly. So PCR will detect mycobacterial DNA. So has been demonstrated in all different types of cutaneous tuberculosis, including the tuberculids. So it is 100% sensitive when it is in multibacillary cutaneous tuberculosis. But in postbacillary tuberculosis, again, the sensitivity is not so high. So that is why we need to consider other criteria as well. So tuberculin test is delayed type hypersensitivity to mycobacterial antigens to intradermal injection of purified protein derivatives, where there are nearly about 200 antigens. So again, because there are so many antigens and host factors as well, specificity is about 2/3, and sensitivity, different studies have shown not to be very sensitive in some situations, especially for the cutaneous tuberculosis. So a positive test can result from clinical or latent infections due to Mycobacterium tuberculosis, as well as from the BCG vaccination or from contact with environmental mycobacteria as well. So then we have to consider the background and decide whether how significant this tuberculin test is. So when it is 5 minutes in duration, is used to determine those at high risk of infection and who are sort of having HIV infection, and sometimes who are having other immunosuppressive drugs, hematological diseases. Even 5 millimeter in duration can be considered as significant for treatment. Then 10 millimeter is used in endemic areas, healthcare workers, etc., and people who have increased risk of latent tuberculosis. So tuberculosis can remain without causing any signs or symptoms in the latent form. So actually, it is said that about 1/3 of the world population is infected with tuberculosis, but luckily about 5 to 10% will manifest clinical symptoms. So 15 millimeter is used in those with no risk factors. So if there is no underlying risk factor, if they demonstrate 15 millimeter, that is indicative of acute infection. So this, I'm not going to go through this sort of busy slide, but there are occasions where this can be negative, although the infection is there. So they can be due to technical issues and as well as biological circumstances like severe disseminated TB. That is a common clinical situation where we have to know when there is severe infection, they may not show positive results for tuberculin test, as well as other forms of immunosuppressions like HIV infection, hematological malignancies, and all the other immunosuppressive drugs. So this is in tuberculin test. It is the testing method is called MAN2 test, where the tuberculin is injected as an intradermal injection, 0.1 ml. So it is described as 5 tuberculin units to be injected to the wall aspect of the fora, and it is read after 72 hours, that is 3 days, and the maximum diameter is considered for the interpretation. So that is called MAN2 testing using the tuberculin test. The other test we can use is interferon gamma release assays or IGRAs. So there are several commercial available preparations. So these are T-cell based blood tests that measure the host response to Mycobacterium tuberculosis by utilizing antigens that are much more specific for Mycobacterium tuberculosis than tuberculin. So this is when it is positive, it is more specific for the diagnosis, but sensitivity may be not much better than tuberculin testing. So the treatment now, treatment for the cutaneous mycobacterial tuberculosis is basically the chemotherapy is same as the systemic mycobacterial infection. So we have to pay attention to the patient as a whole. That is an important aspect in proper management. And obviously we have to look for the internal focuses and get the other specialties to involve in studying the patient situation. And usually in Sri Lanka, we get the help of chest physicians who are very much experienced in managing pulmonary TB patients, so that we get their help in treating these patients. And also the drugs are supplied through the chest clinics. So this is the treatment regime, the standard treatment regime. We have 2 drugs, INH and rifampicin is used for full 6 months, and then another 2 drugs are used only for 2 months, pyrazinamide and ethambutol. So there are other occasions where we have to go for alternative treatments. So in cutaneous tuberculosis, surgical aspect can be useful. For example, excision of small lesions of Lupus vulgaris or Warty TB, and also in Scrofuloderma where there is a large ulcer or sinus formation. And after treatment, to improve the disfigurement, we may need to go for plastic surgical support. So tuberculosis confined to the skin usually responds within 4 to 6 weeks, but still we have to continue for 6 months duration. Few words about BCG vaccination. So here we use the Bacillus calmette-guerin that is purified, the processed Bacillus particles. Bacillus. BCG does not appear to prevent skin tuberculosis. So its protection may last for about maybe 1.5 decades. And so it may not be fully protective for cutaneous tuberculosis. And one another use of BCG is sometimes in bladder cancers. It is bladder is inflated with BCG containing fluid as an immunotherapy. And there are certain ideas that with the COVID infection, India and Sri Lanka, we know our death rates are very low. And so there was an idea whether this BCG vaccination, which is given to all in our countries just after they are born, has an effect on producing protection against COVID as well. So now TB infections showed a very rise with AIDS epidemic. Now with antiretroviral treatment, so that the effect is going down. But we know now we are using anti-TNF treatment for various conditions, including the skin and the rheumatological diseases. So with that, again, TB is in the rise. So exacerbation of chronic infection associated with aberrant granuloma formation can occur on people who are on anti-TNF treatment, as well as while they are on treatment, miliary tuberculosis has been reported, and reactivation. Sometimes we may put them on prophylaxis INH. Still, sometimes reactivation can occur if they are on anti-TNF treatment, because TNF alpha is a major cytokine which helps control TB infection. We know that the main granuloma formation and the lymphocytes are the ones who are mainly responsible for the protective immunity against TB. Other than the Mycobacterium tuberculosis, even non-tuberculous Mycobacterial disease is also associated with increased incidence with anti-TNF treatment. So now we will move on to the clinical entities with Mycobacterium tuberculosis. Primary inoculation tuberculosis is the exogenous inoculation in non-sensitized person. So it is analogous to Ghon's complex in the lungs, where initial infection occurs through the respiratory system. So initially there will be acute neutrophilic inflammation with necrosis and numerous bacilli there. So after about 3 to 6 weeks, it becomes more granulomatous and caseation appears, coinciding with the disappearance of the bacilli. Initially, actually, this granuloma formation was thought to be protective against spread of bacilli, but now they have demonstrated the recruitment of macrophages. With the recruitment, the bacilli enter to macrophages and multiply, but the lymphocytes are the ones ultimately get the disease under control. So in chronic state or the latent state, there may be equilibrium with the immune system and the remaining bacillus. So the other issue is there are some bacilli which are persisters without being destroyed by the antibiotics. So in primary inoculation tuberculosis, after 2 to 4 weeks, a brownish papule nodular ulcer with undermined edges and a granular hemorrhagic base will appear. When obvious trauma is absent, so with minor trauma or without initial damage to the tissue, the initial lesion is can be a small silvery scale and a papule, which may show apple jelly nodules. So we know Lupus vulgaris is the one which shows this feature, but still in primary inoculation, some of them may show this feature. So lesions are commonest where exposed to these inoculations. Regional lymphadenopathy often develops after 4 to 8 weeks. So as a consequence, sometimes these may heal with scar formation. Some of them may progress into development of lupus vulgaris, or Warty TB, or sometimes Scrofuloderma because of the ulceration of the involved lymph nodes. Occasionally, it may lead to systemic tuberculosis as well. So the next form of cutaneous TB is Scrofuloderma, that is direct invasion into the skin from an underlying contiguous tuberculous focus. Usually it is a lymph node, but even from the bone marrow, sometimes this can communicate to the skin. It begins as asymptomatic bluish red subcutaneous swellings, which persists for several months and overlie an infected gland or joint. So they break down to form undermined ulceration with granulate in tissue containing base. In these cases, MAN2 test is usually positive. The immunosuppression. So these patients, when they present, we have to always exclude whether there is any underlying immunosuppression like HIV infection as well as any other uncontrolled diabetes, etc., or hematological malignancies. So these are few pictures. Here you can see the lymph nodes which have ulcerated to the surface skin with undermining edge. And in the other picture also, you can see the same features with ulceration over a lymph node. So with resolving, this can lead to a scar formation like this. The next entity is Orificial tuberculosis. Lesions can occur anywhere on the buccal mucosa or around the other orifices like anus, vulva, or penis. So this is mainly due to the internal, maybe pulmonary, maybe gastrointestinal, sometimes maybe genitourinary tract infection with the lack of immunity. The secretions can cause peri-orificial tuberculosis. Obviously, the patient is severely ill, adult, and the lesions will look small red edematous nodules rapidly breaking down to form shallow ulcers with undermined bluish edges. The plaques can occur similar to lupus vulgaris or hypertrophic lesions similar to Warty TB also can occur. Because the patient is severely ill and systemic infection is there, tuberculin test is often negative in these patients. So this is an example where there are warty lesions with the granulomatous inflammation of the upper lip, and you can see the ulcers over the tongue and verrucous lesions spreading towards the nostrils and the nasal mucosa. So the next the entity is acute miliary tuberculosis of the skin. So all we are talking about multi-bacillary group of clinical appearances. So this is occurring in advanced pulmonary or meningeal and disseminated tuberculosis, commonly in immunosuppressed patients. So there will be crops of minute bluish papules or vesicles, pustules, or hemorrhagic lesions in a patient who is obviously ill. So it can occur anywhere on the skin, but frequently found on the trunk, thighs, buttocks, and genitalia. Sometimes these vesicles may become necrotic to form small ulcers, and nodular lesions also are described. Now, in miliary tuberculosis, the lesions are widespread and more superficial, but in metastatic tuberculosis abscesses, this is disseminated through the hematogenous spread, there will be single or few subcutaneous nodules with mainly fluctuant lesions which break down to form ulcers. So this is an example here. And so these multiple lesions here have opened to become ulcers. So the Warty TB. Now we are moving into the possibacillary group of cutaneous tuberculosis. So here this lesion will be indolent, warty, plaque-like lesion. So this occurs when exogenous inoculation happens in previously infected or sensitized individual who has moderate or high degree of immunity. So due to that, there are only few organisms in these lesions. So they look like warty or hyperkeratotic lesions are there. And here you can see over the leg, the sole of the foot, and you can see the positive mild to severely reactive tuberculin test. So they have good immunity against the bacillus. Next entity is Lupus vulgaris. That is a chronic progressive possibacillary form, again in a previously sensitized individual with a high degree of immunity to Mycobacterium tuberculosis. Then the characteristic lesion is the plaque, in contrast to the hyperkeratotic lesions in Warty TB. So this is a plaque composed of soft reddish or skin-colored papules. Here, when we do the diascopy, that is when we press a glass slide, we may see through the slide apple jelly appearance. That is when we remove the blood in the capillaries, we see these granulomas. So these granulomas are visible in a sort of a whitish, yellowish appearance. So that is called apple jelly appearance. And this can occur in even the other granulomas. So it is not very specific to Lupus vulgaris, but can be a clinical clue for the diagnosis. The edges of the lesion gradually extend in some areas, causing the central scarring. That is another clinical feature. And these lesions grow over months to years. Sometimes they are not so much symptomatic, so the patients present to us late. So sometimes they can be large, extending to a couple of centimeters even. So commonly appears in normal skin as a solitary lesion. So the surrounding lesion area will be normal. So there are different forms. Actually, this plaque form, ulcerative and mutilating form. The lupus word is derived from Latin, I think, meaning wolf. So like eaten by a wolf. So these occur in ulcerative and mutilating forms where there is damage to the deeper tissues. So vegetating forms can be there, tumor-like forms, papular and nodular forms can occur. So recently there are few characteristic features described with dermatoscopy, again giving help for the diagnosis, consisting of linear telangiectasia on a yellow or to golden background and whitish reticular streaks. So these are a few clinical examples. This is the typical appearance with a bit of a brownish plaque lesion. And if you demonstrate the endoscopy, it will show apple jelly nodules. And here you can see the center appearing with spreading bit of a verrucous lesion. And you can see the strong tuberculin positivity. And again, lesion which is spreading with the central scarring. And there can be different forms, as I mentioned. Here, again, we can see the strongly positive tuberculin test involved in the mucosal area and the nose and the lips. and sometimes they can look like tumors as well. These lupus vulgaris can remain for many years, sometimes 1 or 2 decades, leading to squamous cell carcinoma formation and basal cell carcinoma formation. So that is one aspect we have to consider when we follow them up. So at the end of regarding talking about Mycobacterium tuberculosis key manifestations, this is a flow chart which we can use to diagnose, which we can follow to diagnose the or to confirm the diagnosis. So next, we are going to talk about tuberculids. These are cutaneous hypersensitive reactions to hematogenous dissemination of Mycobacterium tuberculosis, so its antigens. From a primary focus in an individual with strong antitubercle cell-mediated immunity. Now, the diagnosis is a bit of a problem in these situations sometimes. So the diagnostic criteria include tubercular histology in the skin biopsy and strongly positive MAN2 reaction and absence of Mycobacterium tuberculosis in the smear and negative culture in the lesion, that is in the tuberculid. So there it is not present, but the infection may be somewhere else. And importantly, resolution of the skin lesions with antituberculous therapy. And sometimes by PCR, DNA may be demonstrated in the lesion. So these are the 3 main groups: micropapular, that is Lichen Scrofulosorum; papular, that is Papulonecrotic tuberculosis; and nodular form is Erythema, induratum, Bazins coming under, or nodular tuberculid. So Lichen Scrofulosorum is seen predominantly in children and adolescents with active tuberculosis. So they will show the positive tuberculin test. They are asymptomatic, tiny, follicular papules, which are skin-colored or bit of violaceous or erythematous and often closely resemble lichen nitidus. So the Lichen Scrofulosorum. So it has a bit of similarity to Lichen nitidus. Superficial dermal granulomas are found surrounding the hair follicles and sweat ducts and may occupy several dermal papillae in the histology. So usually there is no caseation in these lesions. So you can see these tiny brownish papules here, very follicular, and in a relatively adult person, you can see tiny brownish papules over there. Then the papular form is Papulonecrotic tuberculids, asymptomatic clusters of small inflammatory erythematous papules that may become pustule or necrotic and ulcerate occurs, which heal over weeks with rarely forms scarring. So there will be scarring when healing. So that occurs in recurrent crops. The localized forms are rare and mainly involve the genitalia. So generally it is widespread lesions, but localized forms can occur. It may involve the eye as well. Rapid response to antituberculous therapy usually leave the doubt of etiology when a tuberculous focus cannot be found, demonstrated. So it may look like perforating dermatosis where we see in renal failure and diabetes, or sometimes some of them look like papular urticaria, but some lesions may ulcerate in these papulonecrotic tuberculosis. That is, they have form of vasculitis, which leads to necrosis in the supply area. Erythema induratum of Bazin is the most commonly reported tuberculid. There we see mainly a lobular paniculitis with associated neutrophilic vasculitis. The important thing is it has a strong female preponderance. 80 to 90% are young to middle-aged females. Present with a couple of small, tender and painful erythematous dusky nodules seated over the calves, which later on ulcerate with ragged, irregular and shallow ulcers with bluish edge. So heal with atrophic hyperpigmented scarring. Most patients will have positive tuberculin test or IGRA will be positive and respond well to antituberculous therapy. So these are the initial lesions and over the calves, and some of them ulcerate and heal with treatment. So this may take many months to develop and long term to heal as well when they are on treatment. So these have been considered earlier as tuberculids, but they are not classified as tuberculids at the moment. So we know erythema nodosum is an associated manifestation for tuberculosis, and nodular vasculitis when lesions similar to erythema induratum of Bazin develop. They are called nodular association with tubercular TB infection. So lupus miliaris disseminatus faciae is considered as a variant of rosacea, and tuberculous mastitis comes under granulomatous mastitis, where percentage will be due to tuberculous infection. So now we will move on to non-tuberculous or atypical mycobacteria. So the mycobacteria which doesn't fall into the tuberculous group and the lepromatous group are called atypical or non-tuberculous mycobacteria. So they are mainly environmental organisms reside in soil and water. So it is mainly not through the man-to-man infection. It is through the environment we get these things. With the AIDS epidemic, an increase in use of anti-TNF therapy, clinical importance and incidence has increased again. In immunocompetent patients, cutaneous infection is usually as a consequence of trauma and limited to a localized lesions. But in immunocompromised host, there is a tendency to develop widespread or disseminated lesions. So we will talk about Mycobacterium marinum. Actually, we in Sri Lanka see a couple of this type of patients other than compared to the other atypical mycobacteria. So always there is a contact with fish or contaminated water. So they cause infection in fish, and so the fish handlers or people who clean the fish tank develop these lesions after trauma. So that is why they are called fish tank granuloma as well. So after the initial inoculation, that's the trauma, 2 to 3 weeks after the initial trauma in the skin, a nodule will develop. Usually it is in extremity because that is the area where it is exposed, as well as some of these mycobacteria, which are slow growers, prefer lower temperatures. So this may demonstrate spirotrichoid spread. Spirotrichoid spread is where the lesion, first lesion, gives rise to secondary lesions along the lymphatic spread. So that is seen in these atypical mycobacterial infections. Also, it may break down to form an ulcer or remain as a verrucous plaque. The regional lymph glands may enlarge, but usually they never break down like in Mycobacterium tuberculosis. So here you can see the spirotrichoid spread. So that is like a linear spread along the lymphatics, and sometimes ulceration and can occur in the primary lesion. So as the treatment, we can use these drugs, Usually we combine with clarithromycin and sometimes ciprofloxacin or any other drugs, because single therapy is not indicated because of the development of antibiotic resistance. So these combinations are treated for about 6 to 8 weeks or until the lesions improve. So sometimes we may have to prolong the treatment, but usually they respond in a relatively early. Mycobacterium cancers is a primary pulmonary pathogen, but cutaneous infection is seen mainly in immunocompromised patients. Clinical patterns includes again papules, nodules, and verrucous lesions. And with AIDS epidemic, the importance is high again. So these are showing clustered lesions, multiple lesions, and due to the widespread disease. Then Mycobacterium ulcerans is an important species in this group. So it is the third most important pathogen when we leave tuberculosis and leprosy. So it is important and it is in the spread due to the HIV infection. And also the other factors like increased wetlands due to different environmental changes done by the humans can be another cause why this is in spread. So in more than 30 countries, including all the subcontinents, Mycobacterium ulcerans has been reported. So most of the patients are children below 15 years of age. There is a latent period of around 4 months after inoculation into the skin. This gives rise to painless nodule, papule, or plaque, or edematous lesion, which evolves into a painless ulcer with undermined edges within a couple of weeks. Sometimes it may remain as a painless plaque. Anyway, there is little or no constitutional disturbance such as fever or lymphadenopathy. So this main damage mechanism is by a toxin, a macrolide toxin called mycolactone, which is secreted from the bacterial focuses, the foci, which are staying in the ulcer. So this leads to a leukocytoclastic vasculitis affecting the small and medium sized vessels, giving rise to necrosis, and also the fat layer is involved, causing necrosis, and sometimes may calcify even. So after many months of this infection, healing starts and is accompanied by a lymphocytic or granulomatous reaction in the healing phase. So the fibrosis is the end state with the healing. So these mycobacteria can be found in spherical clumps outside the cells and exudate, and also on the ulcer floor and the fatty septi in the deep tissue. So this is an ulcer due to the Mycobacterium ulcerans, and sometimes it can have osteomyelitis and involving the deeper tissues and deep ulcerations as well. The current treatment regime given by the WHO is rifampicin given orally and either the intramuscular streptomycin, so both given daily for 8 weeks under supervision. So they need to be under supervision or hospitalized. Amikacin can be used instead of streptomycin again, either IV or intramuscularly. So this regime to be continued at least 8 weeks is necessary. Surgery will help. If the lesions are very small, only the drug therapy will be adequate, but if they are a little bit larger, then while on drug therapy, they may have to undergo surgical excisions. And if the ulcers are large, again, the surgical intervention will be earlier than the smaller lesions. Mycobacterium avium complex. So this is the skin involvement is secondary to disseminated disease in patients with immunosuppression, which can have variable appearance, multiple ulcers, nodules, ulcerated nodules, abscesses, and plaques resembling lepromatous leprosy or lupus vulgaris. All different clinical forms are being described. So these are a few examples like plaque lesion, nodular lesion, and sinus cracks due to the deeper infections, etc. So now we were talking about mainly the slow-growing mycobacteria. So there is a group which is relatively fast-growing mycobacteria coming under the atypical mycobacterial infection. This includes Mycobacterium abscessus, then Papulonecrotic, Warty group, and smegmatis infection. So these can infect healthy individuals, but most frequently cause disseminated disease in the immunosuppressed. So when it is in the immunocompetent person, there will be abscess formation in the dermis and subcutis at the inoculation site, sometimes with necrosis. So these organisms are widely distributed in the environment. So there may be, these may be found even in tap water. So they have demonstrated even with chlorinated water, sometimes these organisms are being demonstrated. Some of them can remain as commensal organisms on the human skin as well. So in immunocompromised individuals, this may present with disseminated disease with multiple subcutaneous nodular lesions. So they will have subcutaneous nodular lesions, positive cultures in the blood culture, and cervical lymphadenitis. Sometimes it may disseminate into the other organs, to the eye, then the cardiovascular system, the endocarditis, central nervous system, etc. So this is commonly seen in individuals who has genetic deficiency for interleukin 12 and interferon gamma. So in these children, sometimes in early life, they present with this type of atypical mycobacterial infections. So these are few clinical examples. This is on the leg and few nodular and plaque lesions. And so in this group, these are the drugs which we can use. Ciprofloxacin and clarithromycin can be used in combination, or the other drugs can be used always with at least 2 drugs are combined to prevent the development of resistance. So I have come to the end of the brief description about the mycobacterial infections. These are my references. So thank you very much for your kind attention for this lengthy and little bit of boring piece of subject. Thank you. Then I think we can move on to the MCQs. I hope you will find them interesting.
Thank you, Dr. Akarawita. Not boring at all. It was very fascinating. I believe now, Sandarika, you're going to share your screen and we're going to have a short quiz for our audience.
Okay. Okay, we'll move on to the MCQs. There are 6 MCQs with each with 5 responses. So we need to select the responses which are true. First question, which of the following are true regarding tuberculin skin test? A. Purified protein derivative is injected subcutaneously. B. Cellular immunity by non-TB mycobacteria can cause cross-reactive induration. C. In HIV-infected individuals, MAN2 is taken as positive only if the induration is more than 10 millimeters. D. Loss of skin reactivity occurs in sarcoidosis. E. In tuberculous chancre, initial MAN2 is often negative.
So the poll should be on everyone's screen, so you can start to select the answers and submit. Ten seconds remaining on the poll, and then we'll close it. I'm not sure anyone answered the question, Sandrika. I'm sorry if maybe it wasn't, the poll didn't come up on the screens. But do you want to maybe go through the answers and we'll try again with the next one?
Shall I read out the answers then?
Yes, please. Yes.
So first one, purified, the responses which are true regarding tuberculin skin test. Purified protein derivative is injected subcutaneously, which is false. It is injected intradermally. Cellular immunity by non-TB mycobacteria can cause cross-reactive induration is true. In HIV-infected individuals, MAN2 is taken as positive only if the induration is more than 10 millimeters is false. If the induration is more than 5 millimeters, it can be taken as positive in HIV patients. Loss of skin reactivity occurs in sarcoidosis, which is true. It's known as cutaneous anergy. In tuberculous chancre, initial MAN2 is often negative, which is also true.
Great, thank you. Shall we move on to the next one?
Okay, second question. Which of the following are true regarding cutaneous tuberculosis? A. In lupus vulgaris, infection route is always endogenous. B. Tuberculous chancre with regional lymphadenopathy is analogous with Ghon's complex in the lungs. C. Can be treated with conventional anti-TB treatment regime. D. Apple jelly nodules in diascopy confirms the diagnosis of lupus vulgaris. E. Tuberculous gammata are due to Mycobacterium with cutaneous seedings.
So the poll is live again, so I would encourage everyone in the audience to submit their answers now. So 10 seconds left. It is completely anonymous. Okay. I'm not sure if people are having difficulty submitting their answers, but Sandarika, do you want to go through the answers to question 2?
Yes, the true responses. First one, in Lupus vulgaris, infection route is always endogenous is false. It can be exogenous or endogenous. In tuberculous chancre with regional lymphadenopathy, it's analogous to Gons complex in the lungs is true. Can be treated with conventional anti-TB treatment regime is true. Apple jelly nodules in diascopy confirm the diagnosis of lupus vulgaris is false. Although it is positive in lupus vulgaris, it can be positive in other granulomatous diseases as well. Tuberculous gammata are due to Mycobacterium with cutaneous seedings is also true.
Great. Shall we move on to the next one? Thank you.
Okay, it will be discussed by Dr. Subani. Over to you, Subani.
Okay. The third question, select which are true regarding Scrofuloderma. A is due to exogenous implantation of Mycobacterium tuberculosis into the skin. B, the MAN2 test will give positive results. C, occurs only with pulmonary tuberculosis. D, the organism can be isolated by culture. E, should be considered as a differential diagnosis for discharging sinuses.
The poll is launched again, and we'll give everyone 60 seconds to submit their answers. Apologies, I didn't realize that the audience can, participants can actually see the answers on their end. I'm not able to see that, so apologies. Great, so just 10 seconds. Okay.
Okay, so select which are true regarding Scrofuloderma. The first one, it's due to exogenous implantation of Mycobacterium TB onto the skin, which is false. It is due to endogenous spread. B, the MAN2 test will give positive results. That is true. The host is having immunity. C, occurs only with pulmonary tuberculosis. It's false because even TB osteomyelitis can also discharge onto the skin, the joint involvement. The organism can be isolated by culture, which is true, and should be considered as a differential diagnosis for discharging sinuses, which is true.
Great, thank you, Subani. Shall we move on to the next question?
The fourth one, select the true responses regarding mycobacterial infections of the skin. A, can cause ulcers, warty lesions, or papules. B, always manifest MAN2 positivity. C, the clinical manifestations depend on the mode of infection and host immunity. D, more than one infection can coexist. E, PCR has no place in the workup of tuberculids.
Great, so 60 seconds again. Okay, last 10 seconds. Yeah, so Subhani, do you want to share the answer?
Okay, regarding mycobacterial infections of the skin can cause ulcers, warty lesions, or papules. It is true, it can cause a plethora of clinical manifestations. And B, always manifest MAN2 positivity. The stem is false. It can be negative if the patient has no immunity. And also in allergic in cases of overwhelming TB sepsis. And C, the clinical manifestations depend on the mode of infection and host immunity, which is true. These are the two causes, two underlying factors which determine the clinical manifestation. And D, more than one infection can coexist. Dr. Akarawita, our consultant, discussed that there is, when there is genetic deficiency of interferon gamma, they are susceptible to mycobacterial infections. So this stem is true. They can have many mycobacterial infections. And E, PCR has no place in the workup of tuberculids. It is false. It has a place in case of Erythema induratum, where the culture is negative, but the antigen can be isolated with PCR. I would like to invite Kalani for the next two questions.
Thank you, Subhani. Which of the following are true regarding atypical mycobacterial infections? A, Buruli ulcer is caused by Mycobacterium ulcerans. B, patients on anti-TNF treatment are more prone to develop. C, cutaneous infection with Mycobacterium avium complex frequently seen in immunocompetent people. D, suppurative granulomas are commonly seen in early stages. E, individuals with innate defects of interleukin-12 and interferon gamma often shows dissemination of the cutaneous disease.
Again, there are 60 seconds to submit your answers. Last 5 seconds. So Kalani, do you want to go through the answers for
Okay.
5?
So which of the following are true regarding the atypical mycobacterial infections? Answer for the A, Buruli ulcer is caused by Mycobacterium ulcerans. That is true. B, patients on anti-TNF treatment are more prone to develop. That is also true. C, cutaneous infection with Mycobacterium avium complex frequently seen in immunocompetent people. That is false. It frequently seen in immunocompromised people, especially in patients with AIDS. And D, suppurative granulomas are commonly seen in early stages. That is true. E, individuals with innate defects in interleukin-12, interferon gamma often show dissemination of the cutaneous disease. That is also true. Okay, our last MCQ. Which of the following are true regarding erythema induratum? A, it's a type 4 hypersensitivity reaction. B, histology reveals septal paniculitis with vasculitis. C, commonly occurs due to Mycobacterium tuberculosis infection. D, skin lesions usually do not get ulcerate. E, often the organisms can be isolated from the lesion.
Dan, you have 60 seconds. Last 5 seconds to submit your answers. Great.
Okay. True regarding erythema induratum. The answer is true regarding erythema induratum. Response 1, it's a type 4 hypersensitivity reaction. It's true. And histology reveals septal paniculitis with vasculitis. That is false. It's mainly lobular paniculitis with vasculitis. And C, commonly occurs due to Mycobacterium tuberculosis infection. That is true. However, it also occurs with certain other infections like hepatitis C infection and drugs like propylthiouracil. And skin lesions usually do not get ulcerate. That is false. Usually these lesions get ulcerate. Often the organism can be isolated from the lesion. That is false. We can't culture the organism from the lesion. However, the DNA of the Mycobacteria can be isolated by the PCR technique from the lesions. That is also about 50% of the lesions. Thank you, Sandre, and thank you, Sintra.
Thank you, Kalani. Dr. Akarawita, if you still have some time, there were some questions submitted from the audience.
Yes.
Do you have time
Yes.
to go through them? Fantastic. So I'll
Yes.
hand over to Akash, who is going to present the questions.
Hey, thank you so much, Dr. Akarawita. I really appreciated your talk. It was great. There's just a few questions. There's just a few questions that came up. So one of the questions was, why is direct inoculation analogous to the GON complex?
Sorry, why is
direct inoculation considered analogous to the GON complex?
Yes, actually that is now in primary inoculation TB, that is in a non-immune person, where the initial inoculation occurs to the skin. So that is similar to where they develop the GONS focus in lungs and in a non-immune person. That's, I mean, similar pathological process occurs in both sides, but the first entry is here, it is to the skin. So that is why same, pathological process occurs, then spread into the lymph nodes and the lymph node involvement. So that is similar for the GONS focus in the lungs.
Great, thank you. And then the second question was, is the treatment period for all of the different types of TB the same?
Yes, now the cutaneous tuberculosis, all are treated with the standard treatment. So it doesn't change according to the type of lesions. And so we treat with the 4 drugs for 2 months and another 2 drugs for the rest of the 4 months, completing the 6 months treatment regime. So that is similar to the pulmonary TB treatment. So when there are certain issues, sometimes we may alter, but that is the standard treatment.
Great, thank you. One more question was, could you just elaborate a little bit on the difference between miliary TB and metastatic TB? One of the participants wasn't sure on the differentiation.
Right. Actually, now there again in the tuberculous gamma, the spread is hematogenous in both conditions. In miliary TB, the miliary TB involved in the skin, where we get numerous lesions widespread all over the, most of the areas of the body, and the lesions are mainly superficially occurring, going to the dermis. But in tuberculous gamma, sometimes lesions may be a little bit deeper in the tissues, and it will be either one lesion or a couple of lesions. So in they are also the main root of the cause for the lesion is hematogenous spread. So they are somewhat similar, but those are the 2 differences. So I think so that is why these 2 nomenclatures have come up.
Okay, so we just have 2 more questions. The next question is, what is the incidence and prevalence rate of cutaneous TB in Sri Lanka? Is there any data of Southeast Asia?
Actually, I'm sorry to say that we don't have such, data at hand, because these patients are treated in individual places, and so it's difficult to say the exact data. So when compared to the systemic mycobacterial infection, it is maybe only about 2 to 3% of the patients will develop cutaneous manifestations. So it is so now now we are in the central part of the country, in the capital. So still we see a couple of cutaneous TB patients per year, but there are much more cases in the rural areas where these Lupus vulgaris and other forms of cutaneous TB is found and treated.
Thank you. And the final question was, is it possible to distinguish cutaneous tuberculosis lesions from cutaneous deep fungal infection based only on clinical manifestations?
No, not really. So that is one of the differential diagnoses we consider always. So like sporotrichosis example can mimic cutaneous TB, then verrucous TB, especially chromoblastomycosis can look like verrucous TB. So that is the differential diagnosis. We can't be definite just only with the clinical features, but we may have a sort of priority depending on the background, the way the lesion is progressing, etc. So sometimes the histology may give a clue. So there are occasions where we need to go for further investigations to exactly clarify on the diagnosis.
Thank you so much. I think that was it for the questions. Thank you so much for taking the time to answer them.
Thank you very much for the GLODEM team, Sidra, Akash, and Emily, and other members, as well as for all the participant for staying with us for the presentation. Thank you very much.
Thank you, Dr. Akarawita, and I want to again just thank you once more, and thank you Kalani, Sandrika, and Sabani for a really fascinating set of cases, a very comprehensive and thorough review on the topic, and some very interesting questions in the quiz. The feedback's been positive, everyone's really enjoyed it, and thank you once again to all of our audience, especially for your participation, and just looking through our audience members today, we've had really great representation from around the world as always, and thank you again for taking part and submitting your questions. I just wanted to point out a few links in the chat as well. We've got the link for the feedback form. There's also the link for the Gloderm website. So if you've enjoyed today's talk, then please do sign up to the mailing list and you will be kept up to date of future events. I also want to point out that we've also shared the link for the next International Conference on Tropical Dermatology that is being hosted by Dr. Akarawita's team in Sri Lanka. The dates were originally postponed due to the pandemic, so please do keep an eye on the website for any upcoming information. And always we want to thank Dr. Esther Freeman, who's the chair of Gloderm, and the ILDS team, who have always supported us in putting on these events and to ensure that they are always running smoothly. So if people have time, we would love to take a screenshot just to commemorate the event. So if you want to take part in the group photo, if you can all pop on your videos just now, and we'll take a screenshot. Thank you. Great, I'll give you a few more seconds. Fantastic. So 1, 2, 3, cheese. Great, so thank you everyone. And again, Dr. Akarawita and your team, thank you once again for a really great talk. It was a pleasure to have you. All right.
Thank you.
Until next time, everyone. Bye.
Thank you. Bye.